Good morning, everyone. Can everybody hear me okay? All right. We've got a very full agenda here today. We have a great topic. What I wanted to do is just kind of set a framework as to how this panel was started and some other stuff. And one of them is I want to thank everybody. There was a survey that went out to many of the members, or attendees, to kind of ask what are your strategic initiatives going forward on a short-term, long-term basis. And with that, we kind of compiled the data. Then we did a little bit more, some extensive interviews with some of the folks. And if those are in this audience, thank you very much. And then what we did is it actually all kind of compiled together to a white paper that's sitting on everybody's chair. But what we really wanted to take a look at, okay, where is everybody focusing? What are the strategies that we want to move forward with? And so we created a panel, and what we want to do is kind of talk. There's so many different strategies. We've narrowed it down to a few. But what we wanted to do is really kind of take a look at the kind of a payment reform type of a model. Where are we going to be going? Where some folks are today, what they're doing, some of the creative ideas that they have, some of the bumps in the road that they've experienced during that transformation or evolution, which was a common word that we talked a lot about in our pre-meetings. And it was interesting because, I had to start this off, and there was one piece that I didn't really understand, or I was trying to figure out a good topic. And this morning I got an email, and in it was a link to modern healthcare. And in it they had an article, and it was about, and basically what it said was that there was a meeting at HHS, and the Obama administration has said that what they want to do by 2016 is to have, they're currently at 20% of payments for traditional Medicare benefits to be tied to alternative payment models, so whether it's ACO, and they want to go from the 20 to the 30% by 16, and then they want to go to 50% by 2018. So you can really see where they're driving, and I thought that was a great way to kind of just get your head around, yes, this is happening. In some areas it's happened faster, but it is something that's going to be transforming. So that's enough about me talking, because it's really about the panelists that are sitting here. And what I'd like to do is have each one of them introduce themselves and tell a little bit about who they are and what they do with their organization, and then we're going to go into a little bit more depth dialogue after that. Marianne?
Thank you, Bill. It's good to see all of you this morning, and I think we were inspired by our morning session, and we're going to really follow up on a lot of those discussions and principles that were discussed earlier this morning. I'm Marianne Christopher. I'm with THC Consulting, and the perspectives that I'm going to share as we kick our panel off today are gained over a 30-year journey with care coordination. Started with the 1115B waiver models that have been really the precursor to manage long-term care, and then with some work that I had the opportunity to do with Horizon Blue Cross and Duke University in putting together a population health care coordination curriculum and its application to both VNA Health Group in New Jersey and Visiting Nurse Service of New York. So nice to see you all this morning.
Thank you. Monique?
Welcome, everyone. My name's Monique Reese. I'm a Chief Clinical Officer with Unity Point Health. And one of the things, we're a large integrated health system throughout Wisconsin, Iowa, and Illinois. We have a insurance division, a physician organization, home care organization, and we also have hospitals. And I bring that up because the context I'll be speaking to is one of our goals is by 2017 that 60% of the patients we serve will be in some type of value-based contract or capitated payment model. And so many of the things that I'll be referencing today is in preparation and how we've partnered with the system as a home and community-based organization to be of value in that type of payment model. So thank you.
Thank you, Bud.
Hi, I'm Bud Hamas. It says Bernard. I work at Gunderson Health System in La Crosse, Wisconsin. Gunderson is a large integrated health system that has its employed physicians, operates hospitals, home hospice, provides a whole spectrum of care. Also in Wisconsin, Minnesota, and Iowa, just a little bit north of where Monique works, along the Mississippi River. My work, I'm a clinical ethicist, and as I saw clinical ethical problems, I found ways to try to solve those problems, not as a population. And so I've invented a program called Respecting Choices, which engages patients and their families in planning prior to crises so that we're prepared to make those decisions in a more timely fashion. This program has been wildly successful in La Crosse. It's being rolled out, or has been rolled out, in collaboration with our competitor, Mayo Clinic in La Crosse. And now we have transferred it to about 120 other healthcare organizations across the United States. It's widely used in Singapore, Australia, and we're in a large clinical trial in Europe.
Excellent, thank you. Where I want to kind of start off is kind of talk a little about care coordination. And Marianne, I'd like to ask you the question, what are the major variables to consider for care coordination within the model of care?
So when we think about care coordination and population health management, there really are 7 key variables that are critical to consider as one kind of evolves the current practice model to one that will have greater relevance as we move forward. And the first is to really define what the population is, because the population can be very different based on the opportunity that a particular organization might have. It might be a population on a hospital unit, a population of a health system. It might be a population of physician practice, the residents of an affordable housing complex, high-risk members of a health plan, either the high-risk Medicare Advantage populations, the behavioral health population, the managed long-term care population, or even increasingly we see health systems interested in contracting with community-based providers to actually manage the population in hot zones of neighborhoods that really lack primary care access because of the social determinants of care. So that's critically important. The next is to decide the dose of interventions and the type of interventions that are most appropriate for the particular populations that you're under contract to serve. And that would be the blend of face-to-face telehealth and telephonic interventions that make sense for that particular population. The third variable are the mix of the interprofessional team that will be most relevant for that particular population: nursing, pharmacy, social work, and the paraprofessional as health coach and care coordination extender. Key is the whole aspect of patient and caregiver engagement, which Bud is going to highlight significantly in his remarks, and then the whole notion of risk acuity and risk sharing, and how do you really segment the population so you know how to dose those interventions and you know who to put face to face with those folks. And Monique is going to go into some detail about the whole notion of low, mid, and rising acuity in her comments. And you certainly need a very strong system of predictive analytics, so you know what to anticipate and how to intervene in the provision of care coordination. And then what was highlighted earlier this morning, in order to be an exquisite organization in terms of population health management, you have to have mastered and secured partnerships that are meaningful. And so those are the things that we think about when we move forward as an organization in really refining and defining a population health core competency.
Great. One of the challenges, and it's always asked to me, is, how do I do this when there's 2 different really payment models that are going on, and how does the organization structure really need to be? Because we might be talking about a small population, and I've got my core business sitting here. How does one go work through that transition?
And I think every organization is grappling that. We kind of have our feet in 2 very different worlds, right? So the way that I have seen it most effectively implemented is to incubate the population health care coordination division. Let's just talk about it that way for now. And so that those care coordinators who are forward-facing to the partner, whether it's a health plan that you've contracted with under a global risk contract, or a physician ACO with whom you've embedded care coordinators to kind of facilitate the community-based episode of care. those folks are in an incubated unit where they really have the appropriate oversight around the issues of quality management, utilization management, and again, dosing those interventions, what makes sense for those particular people. And they can, depending upon the population, manage between 65 and 150 people. And again, that depends on the risk acuity of the particular sub-cohort with which you're subcontracting. Then what makes most sense is to then contract with your own organization for the component parts that will round out that interprofessional team. So the care coordinators are office-based, and then you would contract with your home care organization or your licensed organization for the face-to-face visits, the intermittent visits. You would subcontract with your licensed organization for your home health aide visits, but they would be functioning more than as personal care attendants. They would be functioning as health coaches, care coordination extenders, embedding a lot of work of Eric Coleman with health coaching into that particular role. That's increasingly critical. And then that would enable you to have the blend of fixed and variable costs so that you can manage to the at-risk contracts that you've secured with whatever payer you're working with. If you're a very large organization with sophisticated information technology, you could go at global risk for 5% of the Medicare Advantage population of a health plan for that whole post-acute episode of care. If you're not comfortable taking that risk, for recidivism rates, then you might contract for a distinct component, the assessments in the home. So a lot of what you're able to contract with depends upon your tolerance for risk based on your fund balance, the sophistication of your infrastructure in terms of predictive analytics and IT. But my belief is, and what I've seen is, there's an opportunity for every organization to contract. I just had a really meaningful discussion with one of the major national insurers, and they said, a licensed organization came to them, not one of the big national chains, and said to them, we have evolved the role of our home health aides. They were able to demonstrate what these home health aides could do through a health coaching construct. They got a higher rate of reimbursement for that particular component than anyone else in the credentialed network. So again, this is an open game for everyone. You have to create the differentiation that has value.
Thank you. Can you describe some of the major intervention elements that comprise the optimal model of care?
Okay, so when we think about, what does that intervention really look like, it's really some of what I just discussed. You need to have, the interprofessional team. You need to have a risk-based construct for interfacing. You need to have that dosed interventions, very, very critical to managing the population. I think what we do with that population varies significantly depending upon, again, the population that you're managing. So you want to make sure that you're risk-based, that you understand risk acuity, as Monique will go into a little bit later. You want to make sure you understand what kind of dosed interventions you need, because as we looked at some of the work that we did with one of the major national insurers with their Medicare Advantage population, we found with a very, very frail, multi-morbid elderly population who were the highest cost to this health plan, only 10% of that population needed face-to-face visits. So think about that. When we think about how we traditionally deliver care in the 90-day episode of over 1,600 members in a pilot that were managed, only 10% needed face-to-face visits of a registered nurse. So again, dosing those interventions, making sure you understand how to manage people telephonically, through telehealth intervention, using paraprofessionals. So downward substitution is a critical component of population health care coordination. What can the advanced practice nurse do? What does the paraprofessional do? What does the nurse do? So those are very, very important, that everyone function to the fullest expanse of practice. And another thing that I have to kind of, where we almost tripped up at one point, is we almost lost the contract, because as the health plan began to look at where their expenses were actually being realized, they realized they had to switch the model that they were contracting with us for, so that nurse practitioners made the assessment visit for those at highest risk, because it allowed them to flip the expense into the medical loss ratio rather than the administrative loss ratio for the plan. If we were not able to be flexible enough to adjust that, and first there was a little bit of resistance in our own organization, we would have lost that contract, because it enabled them to put that expense in another place. And it's very important for health plans to maintain the right ratio of administrative expense to medical expense. So make sure in your own organization you have the capacity to be flexible in the model that you're developing, and that you have the right complement of staff so that you can respond to the changing pressure on the health plans, or frankly, even the ACOs and the health systems, to adjust your model as necessary. And then I think there are endless opportunities.
I think that's interesting because, you really need to understand who you're partnering with
That's right.
and understand what are their challenges to make sure that this is successful.
Yes.
And I think that's a key element that you bring out there. What are the primary clinical and socio-demographic characteristics of the client base under what you've seen under the care coordination?
Okay, so all of the populations that we're called to provide care coordination to share some basic characteristics, some more than others. So if you kind of think about what those are, and then you need to embed into your electronic health record and your predictive analytics system ways to tease that out, and Monique is going to really go into this in some detail, but multimorbidity, polypharmacy, mental health issues, cognitive impairment, clinical complexity, and then the social determinants, homelessness, poverty, health illiteracy. Those are things that we see to different degrees across the subpopulations that we have the opportunity to sell care coordination to in terms of our partners. So then what are those subcohorts? What do they look like? Behavioral health, a huge need right now, as the behavioral health population is carved out of the public payer space and into the private health plan space. Tremendous opportunity for us there. The top 5 to 10% of Medicare Advantage patients who are costing the health plans the most money. Special needs populations, HIV population, and children with special needs. Huge opportunity there, particularly with the new plans, the entrepreneurs who came in through the health exchanges under the Affordable Care Act. Young adult populations with traumatic brain injury. The Veterans Administration now is looking for organizations that can take risk for the veterans who come back with PTSD and also traumatic brain injury. And when you think about dosing the interventions, this is a perfect way to kind of think about that. When you think about, we had particular success with our special needs plan, those folks who had HIV and AIDS. Medication compliance, of course, is so critically important for that population. And we had been running around trying to do like the typical surveillance that we did like 100 years ago with TB. Didn't work. What works with that population is text messaging. And using a text messaging application to remind them about medication compliance, we had an 80% improvement in medication compliance. So we get so wedded to the way we've always done things, but they don't always work for a mobile, younger population. We found the same thing for an at-risk young mothers and children population that we had under contract, running around trying to make visits, people never home. And so we began to use text messaging for immunization reminders, advancing feeding schedules, developmental reminders, and really had much more significantly positive results. We then think about the elderly population. We think, well, it has to be the way we've always done it. If it's not face-to-face, we haven't done it well. But again, I remind you that in this very at-risk population, only 10% of people actually needed that face-to-face assessment. So again, we've got to really become comfortable and exquisitely competent in managing assessments and coaching of patients through modalities other than face-to-face intervention.
It's interesting how, we talk about technology, we talk about how expensive technology, yet you found a very inexpensive solution and you had such a great outcome.
Absolutely.
So sometimes you got to think about out of the box, and maybe it's sitting right in front of you, literally, because everybody's on their phones. that there's something that's there for you. And, of course, there's always the HIPAA requirements behind it, but there are solutions that are coming out that are
Absolutely.
out there that allow you to do that and have that connectivity
Yes.
to the patient and even the patient family. I think
Yes.
that's very exciting. How do the members of the interprofessional team relate within this care coordination model?
So when, I think about the many ways that we kind of applied it, I think there are some really important, learnings that we had. One is that it's a virtually integrated team because, again, it's kind of you incubate the care coordinators, but then you use the assets of the rest of the organization. And so that's important, to create a structure within your organization that's matrixed, where the leadership team is matrixed and everyone has responsibility for the success of the population health care coordination division. I think we have to create within our organizations a shared language, right? And although the care coordinators will emerge as the experts in population health, by virtue of giving everyone access to an electronic health record and they can kind of see the predictive analytics and the characteristics that contribute to low, rising, and high acuity, you're beginning to evolve everyone to this understanding of population health. So I think that's important to understand, that we're beginning to migrate the understanding and the knowledge base, and there's a knowledge transfer as we begin to take this approach of a core division providing population health, but others contributing to that. We're beginning to migrate everyone's understanding to what population health really is. I think then what we need to do externally is ensure that we create the cross-continuum linkages so that whether it's a health plan that we have under contract, a hospital unit that we're kind of applying this construct to, that we're creating the interoperability in our EHR, the consistency in evidence-based practice clinical protocols, so that we can achieve the outcomes that not only we have internally because we're at risk, but what do our partners want? And in doing this with a particular hospital unit with their post-acute cardiothoracic patients, again, the population was the hospital unit. By applying warm handoffs at the bedside with our nurse, the nurse in the hospital, and the patient and caregiver, we were able to achieve an 80% reduction in recidivism rate for those patients. I mean, enormous. And it's just because we created this common language about how to manage that population. So the opportunities are extraordinary.
Great. And not lastly, because there's a lot more, but what are the major relationships in which you're applying this model of care? Who is this? Who are your targets?
Okay, so certainly the health plans are a major target. I mean, they're under the same cost pressures that all of the rest of us are, and they're looking for solutions as extenders to their own care coordinators who have many, many people but don't have the assets on the ground that we do. So that's certainly one of the major opportunities right now. The others, frankly, are the entrepreneurial health plans that developed as part of the Affordable Care Act. I mean, they virtually are shell organizations that are pulling together component parts of other organizations to actually run the mechanics of their plan. So when you think about Oscar Health Plan, it's in the Northeast. They have the information technology platform, but they don't have any of the component parts. They lease that from all different organizations. So they have like a Land's End provider doing the call center, and then organizations like ours provide the care coordination. So that's what we have to think about. People are looking for solutions. Health systems that are looking to kind of go at risk, right? They say they're health plans, but what they're really doing is partnering with other organizations to do that. So minimally, the post-acute care coordination element is at play, and we should be going after every health system kind of selling our competency in that space. So that's another group that we can think about. I did want to just kind of add, Billy, that what we have to think about is, this doesn't happen overnight. We have to invest in really changing the competencies of every single person in the organization. So yes, we talk about who the major targets are. The leaders in the organization have to be exquisite relationship builders. They have to have credibility in the C-suite of health plans and therefore speak their language, in health systems, in emerging ACOs. And although we have had whatever we call them, business development, sales staff on the ground, we have to emerge from being commoditized vendors to virtually integrated partners. And we can do that, but the leadership teams have to really have those relationships. We have to make sure we have advanced practice nurses if we're going to be able to sell to the medical loss component of health plans. And we have to have staff who can do population health care coordination. There are many universities emerging into this space. Duke has an extraordinary platform. It's a one-semester curriculum course. Many of the health systems are using it. The Blues are using it. I've used it with great effectiveness. And anyone that you have forward-facing to a customer, anyone, whether it's a physician practice, ACO, they have to have understood and embraced and immersed themselves in the whole competency of care coordination. And anyone that you have placed in the hospitals, they have to have emerged as population health care coordinations and transitions of care expert, or it's a wasted resource. It really is. The whole notion of I'm going to get the next referral, forget it. I don't want the next referral. I want the population, right? That's the real play right now. And then if we aren't evolving the role of the paraprofessional to health coach and care coordination extender, then somebody else is going to come in and they're going to create community health workers or whatever they are. We have this resource within our organizations, and if we don't advance that skill set, it's a missing opportunity. Bill wanted me to mention, how do you pay for it? We were able to get a $500,000 grant through workforce development because there's a lot of money coming out of the feds for that. We had a foundation that offered, these big corporations have a responsibility to their community, especially entry-level workers. Got a huge grant to be able to build the health coaching into the paraprofessional workforce. So the opportunities are endless.
That was the accountant in me that had to ask that question. When we take a look, I want to kind of change gears a little bit and kind of talk, Monique, talk a little bit about your experience. And what I want to ask you is, when we look at this, what are the competencies and skills does a clinician need to display for success in these models?
A couple things. When I was thinking about this, and Mary Ann's comment, it wouldn't be just the competencies of a clinician. So I think I came up with and looked at, as we've been through this journey over the last 5 or 6 years, we're at risk now with our populations. It's competencies from the board level to the bedside. And so definitely with our clinicians, but also from a board standpoint. So we've been building a foundation over the last 5 to 6 years. And when we look at that, the ability to practice to the scope of your license, if you're a clinician, or the scope of your degree is extremely important. Our ability to motivate and engage in shared decision-making, and Bud will speak to that in more depth, but that's really going from some of those more paternalistic models of approach to patient care to actually partnering in becoming a partner in that shared decision-making. And the importance of that is key, and I wouldn't underestimate the skill building that's needed in that area, at the boardroom and at the bedside. The ability to use technology. I think Mary Ann referenced several great things, and that could be low-cost technology in regards to use of text messaging to virtual visits, e-visits, and so forth. So we've definitely continued to educate on the competency and skill building in that arena. The ability to explain and use evidence-based tools, evidence-based care protocols, and so forth become extremely important as a competency. Mary Ann talked a lot about managing populations and population health. That is a game changer in regards to having individuals, again, both at the board level and at the bedside, understanding the difference between episodic care in one point of care versus managing a population over a time period. The approaches in identifying and managing the illness. And so some of that gets a little bit into the risk stratification. So what we actually did was very similar to what Marianne was talking about in regards to high, rising, and low risk. And so we segmented our populations because we're in value-based contracts. That gave us access to claims data. And so we began using that claims data to identify, based on certain criteria, who would fall into high, who would fall into rising, and who would fall into low. And we specifically put interventions in those areas. So some examples for that would be in the rising risk, we began implementing the known patient-centered medical homes. And from a home health and a community-based organization, we actually took individuals that were home care managers, clinicians, even some directors, because they were so excited about being part of this transformation. And they became care coordinators in the patient-centered medical home. So what we really started to design was that integration between care settings, and we started to transfer that knowledge. And so that was really key for us. And I think as we look at partnering, and how could we be good partners to both physician organizations and or hospitals and other partners, those are the kind of things that we think, we have the workforce, we can help you here. Those are going to take individuals that have the competencies that I listed. Interprofessional collaboration is extremely important. I know for us, most of the clinical models that we are implementing are based on interdisciplinary teams or team-based care. And so the ability to leverage each other's skill set and work together is extremely important. I actually think we have a long ways to go there from an academia standpoint. And so a lot of that, what I would call administrative burden for these competencies, is on us as an employer at this time versus you actually learn that when you're going through your training. I think there's a big gap in that area, and we have a lot of opportunity, and Bud will talk a little bit about that and some of the experience that he has. But currently, right now, we are training clinicians, leaders, as they come in internally.
I have a question on the, you had mentioned the board to the caregivers, and I know in my travels I've talked to a lot of folks, and in many instances there's so many roadblocks at the health system level where they don't either understand or fully grasp what it is that we do. And so maybe talk a little bit like, how do you get through that? I mean, can you give somebody some advice? Because I think that's a big challenge.
We've been working on getting through that for about 10 years.
Oh, so it was overnight.
Yeah. And so I've actually, I've been with the health system I'm at now for about 12 years, and I kind of grew up in it. And so it was interesting, and I worked in all different settings. So I bring that up because there's a lot of that cross-learning, and Marianne, you spoke to it well in regards to individuals or leaders who understand how to work with a health plan, how to work with a hospital partner, how you work with a physician organization. Some of the things that we did, and again, this is a decade journey, and so some of it's we're super excited, and some of it's been painful, is we actually, when we put our board together between our home health organization and our physician organization, we have some like members. We have separate boards, but we have some like members. We definitely have some CEOs from a hospital care setting that within our system, and also physician organizations. So you start to see we're trying to bring in this interdisciplinary executive leadership team in that board makeup. Because part of that is, and so it starts when I think of the board, some of that strategic planning component, having some different disciplines in there that understand the home and community, understand population health and where we're going is critical in our ability to remove some of those barriers and, in my opinion, proactively plan. The other component that we did in this arena is we began developing some shared roles. So I was historically the chief clinical officer within our home care division. My role expanded into the physician organization, and then I also work on some system-wide initiatives. And so you start to look at how we're leveraging executives to drive some of that integration at strategic points. For example, the PCMH and how we can leverage community and home-based to build that PCMH. The other would be transitions in care. I lead that initiative at a health system, and so we're trying to leverage the importance of home and community-based in transitions of care at different points, not just post-acute, but we're actually moved into the pre-acute, and how do you proactively identify and that those transitions happen before you're ever in the hospital. And that's extremely important when you get into more of those value-based contracts and capitated payment models. It's not about re-hospitalization, it's about avoiding hospitalizations and or high utilization that's unnecessary.
Great, thank you. Because I think it is a challenge that a lot of us face on a daily basis, and it's something that, you know, again, it's kind of, you got to keep figuring out a way to work around it until maybe and hopefully it does take hold.
Yeah, you got to try it like 3 or 4 times. I know.
That's it?
Yeah.
I'm
There's a lot more than 3 or 4, but.
You mentioned the PCMH. What clinical programs do you see as imperative for success in the future payment models and alignment with the PCMH?
You know, it's interesting because when we look at PCMHs and we look at NCQ certification, and you know, you can go a couple different approaches. You can go, you know, you want certification in what I call more of a checkbox, got it, and or you can look at it and leverage that model to transform care, because there's really a couple different ways you could take it, in my opinion. And so as we've looked at that, we're looking more at an investment in transforming the care delivery component of this. And so as I look at different programs, I look at palliative care as a program, and when I first sat at the table, I'm on our PCMH steering committee, and I recommended this. It blew their mind. They're like, what? And it really gets into that pre-acute and that proactive planning that's so important. And so what we were able to do was, you know, we've been in that realm, and we've been the experts within our system for over a decade. We had plenty of data to show that if there's an intervention with palliative care in the acute, we know we can decrease cost utilization and improve quality and experience by about 50%. We also have data that shows if we actually reach those patients in the community or the clinic, that we could move that by 70 to 75%. And so really use that data to say, no, this really makes sense. It's the right thing to do. Oh, by the way, it meets NCQ certification in multiple ways, whether it's shared decision making, whether it's having a palliative care program that you connect to. So one of the things I think we can offer as an industry is the leveraging that workforce. The other thing I would say is that our palliative care programs are a consultative model, and we also, they are teams across the continuum. So it is a team in a region, and they work across hospitals, clinics, and the home health arena. And that's really key in regards to how the design is, at least for us within the system. That's been extremely imperative. Another component that I think is important with the PCMH is, in the earlier session, there was some mention of participating in waiver programs. And so one of the components of being in a pioneer, the MSSP, was that we could leverage these waivers in delivering new ways of care. And so we've actually been able to partner with our pioneer and our physician organization to provide those care at home visits that wouldn't meet your traditional certified your business. And so we've been able to be at the table, leverage waivers to provide non-traditional care, and show that value in the skill sets that we've built. And there's lots of different models. We call them care at home visits. It could be some of the transitional care management type models also. But the ability to participate in waiver programs, I think, is extremely important when we're partnering with PCMHs. I also, the ability to have care transition processes in clinical programs, that's extremely important from a PCMH standpoint in managing populations. And so when we look at that, and we look at, I actually think PCMH is a component, and where we'll really end up in parts of the country are there already is more medical neighborhoods, and how we partner as that community and home health expert in that larger picture of a medical neighborhood. And so care transitions is a great way to do that from within our physician organizations. There are not the competencies or the skill sets in that. I can tell you in our industry, we have those. We can teach those in a pretty rapid pace. And so being able to partner with that PCMH and care transition in those processes is important. And then finally, I think in this area, advanced care planning. When I say advanced care planning, this is a foundational item that I think we could provide value in, and Bud's going to go into more detail in regards to that. But us being able to partner with PCMHs in advanced care planning, it is another key component for NCQA certification within PCMHs. The difference is it being meaningful, and I talked about the checklist versus transforming care. Handing out a pamphlet and checking a box is not the same in actually sitting down having a conversation early on or at end of life. So I think advanced care planning is another way that I know we've partnered with our PCMHs. And we can tie this all back to value when we look at HEDIS measures and other ways. I think it's important to talk about how can we do this and what's the value to you as a PCMH, and tie that back in their language so it makes sense. It would be extremely important. I only had one final component on that one that I think is important, and Marianne mentioned this, is the use of nurse practitioners. And so as we're moving from episodic care into more population health and managing populations, there's different literature out there that talks about what kind of ratio should you have from a provider standpoint. And some suggestion that for every physician you should have 4 advanced practitioners, whether that's nurse practitioners or physician assistants. And I think that's going to be really key from an economic standpoint, and there's plenty of research out in regards to patient experience and value to where it's very comparable, whether it's a physician, nurse prac, or a physician assistant. And so I think the use of nurse practitioners in that PCMH model is going to be extremely important. I know for us in our health system, we are not there. We're 2 physicians to 1 nurse practitioner. And so that's one of those barriers that may take 3, 4, 10 tries. But the culture component of that. But I think the other part of that for us as an industry is to continue to advocate in regards to, for us, another barrier that we run into is we're in 3 states. So the practice laws in those 3 states are different. So you could imagine being part of a physician organization that's across 3 states, yet the practice laws for nurse practitioners vary greatly. And so trying to manage that becomes extremely difficult. So we need to be proactive in regards to the licensure and that being like or having compact states within that. It's going to be extremely important in our industry too as we cross states in some of this work.
Excellent, thank you. Just one that I think will actually segue with Bud also is data. And do you think the systems that are out there and some of the IT systems are providing the data that's needed? Is it, where do you think we are with the data component to it and data warehousing?
I think we have a lot of data. With that said, I think we have a gap in it being meaningful and useful. I would also say in my experience is we have a lot of data. We can get a lot of reports. I can look at them and I have no clue. It is so much information. So the opportunity for us from a data standpoint is to make that meaningful. And where we're at right now is that there's a huge administrative burden on the provider organizations to figure out that data. So we're hiring all these analysts and so forth to dig through, compile this information so that it's meaningful. So I think we have a lot of work to do in regards to the data component. I mean, I think we're getting closer to more predictive analytic capabilities, but in my opinion, those are the game changers because that's the real time information that you could have at the bedside to make a decision that's going to affect the next 6 months of someone's life. So I think part of that data is the use of our electronic health records is extremely important. I know for us at the health system, we're currently building that foundation now, but there is a huge burden on the amount of data and the big data that we have and how we have to compile it, massage it to make it meaningful at the bedside.
Thank you. And Bud, you gave a brief description of your program in the beginning. Could you kind of go into a little bit more detail as to, because you've made some great strides in your program, so maybe kind of go a little bit more into that if you could.
Yeah, good morning. It's great to be here. I think the thing that we did differently in La Crosse that really has been a game changer and really supports the kind of work that Marianne and Monique are talking about, is thinking about advanced care planning as a process and as part of a system. So we really worried about, first of all, the quality of the planning process and training non-physicians to have these shared decision-making conversations with patients and their families so they could really identify what their goals of care would be and when those goals might change. This is very different than just filling out a legal document, which clearly doesn't work. It's a waste of time. Quite honestly, it probably gets you in more trouble than it really resolves. What you really need are these shared decision-making processes with trained staff. But the training has to be standardized, because if one nurse has one conversation and another nurse or another doctor or another nurse practitioner has a different conversation, it doesn't help. So the second thing is having high-quality conversations in a standardized way, then documenting these in a way in which they reliably get in a chart and can be discovered by future clinicians at any setting of care. And that's what we've achieved in La Crosse. We do this now in 3 stages of planning across the lifetime of a patient. So there's more than 3 conversations, but there's 3 distinct types of conversations we call first steps for healthy adults, next steps with patients who have advanced illness, suffering complications, much of the population that's being talked about here, and then advanced or last steps with patients who we wouldn't be surprised if they died in the next 12 months no matter what we did. The content of each conversation is a bit different, but it becomes part of the culture for both patients and providers. We have documentation systems, so in La Crosse, just to give you some numbers, residents of La Crosse County who die in any setting of care, 96% of the time have a written care plan in their medical record at the site of care, and it's honored consistently 99% of the time. This is achievable, but it requires a transformation in how we train people, the workflows, the EMRs. All of this stuff has to be built into an organized system that's managed over time. And it improves satisfaction of patients and families, it improves quality of care, and it drives down unnecessary acute utilization. So this is meant to be supportive. This is a way of actually training health professionals and health systems to build this in. Now, just to get back to Monique's point about data and electronic medical records, we surveyed our physicians and said, are you willing to bring this topic up? Well, first of all, we found out that we needed facilitators, trained non-physicians to carry out the conversation, because a physician is not going to spend 30 to 90 minutes on a conversation about future care with patients when he or she has a waiting room full of people or a hospital with lots of patients to see who are acutely ill. So we had to have these facilitators, and it's extended then our ability to provide this service. But the second thing the physician said is, I'm willing to bring it up if someone else is going to carry on the work, but I need to be reminded. So we can build prompts into our electronic record so that certain triggers go off and the physician is saying, this is a patient where you need to introduce this conversation. They're willing to bring it up, they need to be prompted, they need a referral system to a trained staff, and this dramatically increases your capacity to have these conversations, and I think the outcomes really speak for themselves.
Question I have is the patients. How are, what's their reaction in the beginning to start this dialogue, and how do you get that ball rolling?
Sure. So initially there was a lot of fears, concerns. Why are you doing this? What haven't you told me? There's some really understandable and I think predictable evidence. So we did several things. One is we put a poster up in the exam rooms in primary care, oncology, cardiology, and this poster had our logo, which image that we had, and it had this simple statement: we can't respect your wishes for future medical care unless we know what they are. Ask us about advanced care planning. Now, so we wanted our patients, whenever they saw their doctor, to know that advanced care planning was part of the routine of care. But beyond that, as some of you probably know, we partnered with our churches with home health, with hospice, with our nursing homes, with senior groups, with service groups. We pushed basic, at least first steps advanced care planning out into the community. And when you have a standardized program, you can train people like parish nurses to start doing advanced care planning at no cost to the health system. And a lot of people prefer to talk with their parish nurse than with someone in the clinic.
Excellent. And in terms of kind of like the financial piece to it, because obviously everything kind of evolves around back. I'm an accountant, I have to go there. What have you seen in terms of outcomes, and has it helped along the road?
Well, looking at the use of hospital utilization and the cost of care, the total cost of care in the last 2 years of life, Gunderson has the lowest in the country, if you look at the Dartmouth Atlas. We have driven down the cost of care so that we're using 9.7 days of hospitalization in the last 2 years of life. Now, there's a lot of factors to this. This is not a randomized controlled trial. But all of the trials that I've been involved in show a reduced utilization of hospital services. One of the things that our palliative care team in the hospital remarks on is the thing that they noticed being different from where they used to work is palliative consults often start in our emergency room, not after 5 days of ICU care. The reason is because in our emergency room, when a patient comes in and now has had a new devastating medical problem, there's so much information about that patient's preferences in our chart, and the family has been involved in those conversations. Decisions can be adequately processed in the emergency room. So the call is, we have a patient here, the decision is for them to go into hospice care. Would you come down and take over management of the patient? And our palliative care team then goes down and admits that patient into the palliative service rather than the neurosurgery team coming down, taking them to surgery, and then putting them in the ICU, and then after 5 days saying, well, this didn't turn out well.
That's great. How are families embracing this? I mean, I could see maybe some, my wife's a nurse, and many times she'll come home and tell stories where the family wants to do everything, and it might be against the patient's ultimate will. How do you see that?
Perhaps the most interesting story, we had a national public radio reporter come to La Crosse, and she, unknowns to us, walked around a city block, knocked on doors late in the afternoon and early evening, and interviewed everyone in that neighborhood. Only one couple didn't have their advance directive completed, and that couple admitted they were receiving pressure from their neighbors to get that done. It has become part of the culture of our community because the benefits to people is so clearly great. And currently, I am approached usually about once a week by a stranger who says, thank you. And I say, well, I don't know you, I don't know what you're thanking me for. And they usually tell me a story about a loved one who recently died, and because of this program, their family was prepared to make the very difficult decisions in a way that has left them sad from the death, but at peace with the decision they made. And they saw that as a real gift. And so I think reaction of both patients and families when they really participate in this is an improved sense of care. And there's actually data from an Australian study that used our program that showed that not only did people appreciate the help, but everything else they evaluated in terms of satisfaction of care was dramatically increased. So this was done with a population of 80-year-olds. Their doctor was better, their facility was better, their nurses were better, and so forth. So 2 groups of patients randomized, being cared for in the same units by the same doctors and the same nurses. Those patients who got advanced care planning evaluated or were more satisfied with everything about their hospital experience compared to controls. The only difference is the people who got advanced care planning had a nurse come in and talk with them about end-of-life issues for 60 minutes.
Great. Do you see any challenges with, ethnic groups, or because some of us might be in a city where there's many different pockets of multi-international type
Sure.
setup.
It's a great question because La Crosse is about 98% Caucasian. So it's an obvious and good question, and we worried about this. We have successfully implemented this in Australia, Singapore. Right now it's being rolled out in Kaiser Permanente in Northern California to 3.3 million people. We have not seen any problem with ethnicity, culture, and I think the general explanation I can give to that is this approach is so person-centered. It always starts out with, we want to take better care of you, we need to know who you are. And once you start from that premise, I'm not going to tell you anything. You're going to tell me who you are. You're going to tell me what your goals of care are, and I'm going to help you clarify those and talk with your family about those. And it's that which is going to help us shape how care is going to be delivered. It doesn't matter then what your ethnicity is, your culture is, because we can be respectful for the differences that may occur.
That's great. Thank you very much. That's,
Of La Crosse? Well, this population that our health systems, there's two competing health systems. We provide services for about 560,000 people in 19 counties. The population that we've studied is 120,000.
are there any other questions? Okay, great. Thank you, Bud. That was great. What I just want to kind of wrap up the session is, again, we kind of talked a little bit about payment reform, our alternative payment models going forward. There are other topics that were identified in terms of strategic initiatives going forward. And the one I don't want to go into too much detail, but I really want to kind of just make sure that I say it, and it has to do with culture, and it has to do with our staff. And a lot of the challenges that people are facing as they move forward is that, do we have the right staff? Do we have enough caregivers who can take care of all of our patients as we move forward? And I think that's a big challenge, and we have to start thinking a little bit out of the box as to what we need to do and how we need to educate some of the individuals. Maybe it's going to the universities and trying to see if we can get the track a little bit faster. You know, we talked a little bit about how typically a home health nurse has maybe 5 years, acute care experience, and then they're able to go out. Well, is that the right model, and can we sustain that, knowing what's happening in the acute care settings as well? These individuals need to be trained and need to move forward. And it's also, I think it kind of stems back to looking at our own patients, and a lot of the initiatives we're in here in terms of staff development, managerial and leadership training, and really just reignite the energy within our organizations as to what we do and how we do it. I think many times, as it was mentioned, we get task-oriented, checking the box, and I think we need to sit back and try to educate the caregivers as to, this is the vision, this is where we're going to be moving forward to. And every time that I've had that conversation with folks, whether it's been on a strategic plan type session or anything like that, there's energy, there's excitement. That, it's like the caregivers, this is what they want to do. So I think we have to kind of keep that momentum and see what we can do going forward as we move down the pike. And some of the other stuff that was in there, again, mergers and acquisitions and some cost containment and all of those. And I think the key on the mergers and acquisition, what we heard a lot about, is partnership. We might not need to be the be-all to everybody, but we need to be able to be partnered with those to help us provide the care that's going to be needed and be part of that post-acute, pre-acute, whatever that might be, but we're part of that. And to make sure that those organizations know what we do. There's times I walk into health systems and all of a sudden the CEO or CFO or whomever I might be talking to, they're all excited about a new pilot program that they're starting up. And I sit there and go, do you realize that that's what your home care does every single day? Ask those questions, and we need to be the champions as we move forward with those things and really make major changes within how we provide care, but think out of the box also. Can we do things in a private duty setting that will allow us the flexibility from a regulatory perspective to do that practice? Know what's happening with your state. If there's things that may need to be changed within your state with regard to regulation, try to push the agenda. And I'm not talking about regulations that's going to hurt the patient. What I'm saying is regulation that doesn't need to be there in order to provide the care for that patient. Do I need to fill this whole OASIS document out when I'm just trying to do something that's going to meet that patient's need? What can I do? Help me with this. We want to be able to do it. You've got to help us as well. So with that, I really want to thank the panel. There was so much passion that we had, and I think it came out in the conversations. I want to thank Bud. He came in from Cancun on a family vacation. So, but thank you again, and thanks everybody for listening.